Good evening. My name is Tim Gibbs, Director of Delaware Health Force. Welcome to the late spring series of Delaware Mini Medical School that we are doing in partnership with ChristianaCare. We're live streaming on YouTube. There's the address, and Nicole will put the direct link into the chat. As I mentioned, for past video recordings and for the PowerPoint presentations, you can go to delawareminimed.org. Housekeeping tips, and we're gradually, as I say each week, we're taking a little more of the content that we said in the beginning and taking it out. This is a Zoom webinar, not a meeting, so we can't see you. You can see us, you can't see one another. Please only use the Q&A feature to ask your questions. Questions will be answered at the end of the presentation. Please don't ask questions of a personal nature. We respect privacy very highly. And if it's an interesting question that we can figure out a way to ask and make it anonymous, we'll try and do that. To the best of our ability, all questions will be addressed. Some by staff if it's housekeeping related, others by our presenters. You do need to stay through the entire presentation to be counted as present. However, at the end of the official presentation, when we go into Q&A, that's when you can leave. Although, as always, that's when a lot of the good stuff actually comes out. We do Delaware Mini Medical School in partnership with the Sussex County Health Coalition. And at this point, I will turn it over to my colleague, Christy Handley, to talk about the coalition and to introduce our convener for this evening. Christy, over to you.
Great. Thank you, Tim. As Tim said, I am Christy Handley. I am from the Sussex County Health Coalition, where we engage communities in collaborative family-focused efforts to improve the health of children, youth, and families. We do that by giving a voice to our community in order for them to voice their concerns and ideas, and for us to advocate on their behalf, building capacity for policy and program development. Next slide. This evening, we have Tabassum Salam, who is joining us as our facilitator. She is a board-certified internal medicine physician with 20 years of multifaceted experience in healthcare. In her current role as Chief Learning Officer at ChristianaCare, Dr. Salam works with a multi-professional academic affairs team to deliver learning and professional development programs to physicians and other clinicians at all stages of their education. She received her medical degree from University of Pennsylvania, Perelman School of Medicine, and her MBA from Wharton School at the University of Pennsylvania. Thank you for joining us, everyone, and I'm going to turn it over to Dr. Salam.
Good evening, and thank you so much for inviting ChristianaCare physicians and other providers to bring their insights to the Delaware Mini-Med audience. I'm especially excited today to introduce 3 of our amazing caregivers. The first person you'll be hearing from today is Dr. Emmanuel Mensah. He's the Chief Medical Officer of our Wilmington campus of ChristianaCare. He's a hospitalist and clinical assistant professor at Sidney Kimmel Medical College at Thomas Jefferson University. He earned his medical degree and MBA from Harvard University. He completed his internal medicine residency at Beth Israel Deaconess Medical Center in Boston and studied mathematics and biology at Dartmouth College. Throughout his career, Dr. Mensah has developed an interest and expertise in health equity and disparities, quality improvement, and health system design, with a focus on global health and developing countries. He's going to be joined this evening by another colleague, Dr. Stephanie Guarino, who is a lifespan hematologist-oncologist. She serves as the Medical Director of Adolescent and Young Adult Oncology at Nemours Children's Health and is the Medical Director of Sickle Cell Disease and Transformative Therapies at ChristianaCare. Her research focuses on the management of chronic pain in adults with sickle cell disease and improving services for adolescents and young adults with oncology diagnoses. She earned her medical degree from Baylor College of Medicine and completed her residency in internal medicine and pediatrics at ChristianaCare. They are going to be joined by a third colleague today, Laurie McNamara. who is a licensed clinical social worker. She's embedded at the Center for Special Healthcare Needs in outpatient primary care clinic, where she supports adults with childhood onset chronic illness who have transitioned into the adult healthcare system. She has spent the last 5 years working alongside patients who are seen in the sickle cell clinic housed in their program, and she assists with connecting patients with community resources, navigating insurance issues, and continues advocacy to promote improved health outcomes and equity. She earned her Master of Social Work degree from Widener University. So, colleagues, before you dive into the wonderful program that you've put together, I think it'd be really tremendous for the audience to hear a little bit about your own educational journeys and how you came to practice in the settings that you're currently practicing in and the roles that you have. Dr. Mensah, I'm going to invite you to lead things off.
Thank you, Dr. Salam. Good to see everyone. As I was introduced, Emmanuel Mensah here. I'm the Chief Medical Officer at ChristianaCare Wilmington campus. My journey, actually, I'll start from high school. I went to a unique high school called a United World College, and there are many of them around the world. At that time, there were 10. This is a school for 200, at least the one in Canada I went to in Victoria, British Columbia, was 200 students from over 90 countries, where I studied the International Baccalaureate program, a 2-year program, amazing opportunity, meeting all these different colleagues from different parts of the world. That education program is what helped me transition to the US to go to Dartmouth College. Originally, I'm from Ghana, and I'll talk about a case from Ghana. And at Dartmouth, studied biology and math, as Salam said, and actually worked on Wall Street briefly at Goldman Sachs. And then the financial crisis hit, so I ended up going to medical school, where I went to Harvard and did my MD, and also at Harvard Business School to do my MBA. Stayed at Harvard for residency, but during that time, I also worked at McKinsey doing management consulting, which was very interesting, working the business side of things in healthcare. Finished residency, I was doing both. I was working in business at McKinsey. I was still at faculty at Harvard Medical School and seeing patients at Harvard and Beth Israel, and also doing some clinical work in Ghana. And this case came from one of those experiences. Transitioned out of the business world and ended up becoming a firm chief at Harvard and Beth Israel, and also being the managing director of a center. And for the global health part, I will not spoil the tea. I will share some of those pictures and some of those stories of my time doing global health work. This was a great transition to Wilmington to become chief medical officer here, because at the risk of sounding arrogant, I like to say that I'm not here to be a CMO of the hospital, but I'm here to be a CMO for the community. And so bringing that private sector business work I did with McKinsey, the public sector work I did with my work with WHO and Africa CDC, which I'll talk about, and obviously the clinical part, all into the role of chief medical officer. And so that's my journey. And I look forward to sharing some of it with you through pictures and this case. Over to you, Dr. Salam.
That's wonderful. Thank you. Laurie, would you like to go next?
Hi, everyone. Thanks so much for joining us tonight. I am going to test my memory to share with you my education on how I got here. I actually started as an undergraduate at the University of Delaware, originally coming from New Jersey, and started my educational career there in history education. About halfway through my freshman year, I decided that this is absolutely nothing that I wanted to do, and promptly made the switch to obtain my undergraduate degree in human services, where I learned a lot more about servicing the community and really what it meant to be a caregiver and a person who kind of aligns themselves with the goals of those in the community that need assistance. So my senior year of college, I had the opportunity of completing a internship at Exceptional Care for Children, which is a pediatric skilled nursing facility caring for individuals that are chronically ill since childhood. And actually got hired there upon graduation and completely fell in love with the population, the patients, the families, and decided to pursue my master's degree in social work. I felt like that was the next step, and I was able to obtain my master's while working full-time, and I got my degree part-time, and they were gracious enough to support me doing my 2 required internships for my master's degree. So My first one was at Cancer Support Community, located in Wilmington, Delaware, where we run support groups for individuals that have and their caregivers that have a diagnosis of cancer, any type. And then my second internship was actually through ChristianaCare, where I got to get my foot in the door a little bit and learn more about their programs. And in 2020, I actually joined the team over at Christiana right before the pandemic. So it was a little non-traditional of a start. But that is where I got connected with the adult population of individuals living with chronic illness and Dr. Guarino over at the sickle cell program. And then following getting my master's, I did an additional 2 years of supervision to sit for my licensing exam to become a licensed clinical social worker, which is was a really big accomplishment that I'm proud of. So in addition to working at the center, I also do talk therapy in the evening with adults, young adults and adults, to kind of just exercise a different side of my my social work brain. So get a little bit of, both worlds. So I'm looking forward to talking to you guys a little bit more tonight.
That's wonderful. Thank you for that. I always love the fact that we all in the world of medicine work in interprofessional teams. And I love when we're able to recognize different disciplines, different routes to training, but the fact that we all come together to take care of our patients in a team way. And that's lovely. To round things out, Dr. Guarino, we'd love to hear the same story, but your version.
Sure. So I went to a science and technology magnet high school in Texas and knew I wanted to do medicine early on through some experiences, volunteering at hospitals and things like that. I was lucky enough to be accepted to medical school out of high school through one of the dual admission programs. So I took some time to, I studied neuroscience in college, but also got a liberal arts degree called University Scholars and wrote a thesis with some of the social workers who were some of my favorite people that I met about gender and poverty's influences on access to treatment for HIV/AIDS in the global South. So that sort of kind of passion and bent came early. The best piece of unsolicited advice that I can give you in terms of thinking about your undergraduate or any sort of training is even if you want to do medicine, take some sort of classes or pursue opportunities where you learn to read and write and communicate, because those are things that are so important in practicing medicine. My patients, I think, remember more about our interactions and how they felt during them rather than maybe some of the medical information that I told them. So anything that can help you practice those skills are quite useful. I did go right through to residency and fellowship in Delaware. Moving from Texas to Delaware was a little bit of a new experience, but good enough that I've stuck around and have worked since 2018 to grow programs at Nemours and Christiana.
This is fantastic. Thank you for that great start to your presentation. I'm going to turn things over to you. Take it away.
Thank you so much. And I'll project my slides and we will get started. Good to see you all. And I hope everyone can see my screen. Dr. Guarino, you see my screen? Perfect. So let's rock and roll. And I'll be calling on Dr. Guarino and Laurie to help me out here as we go through this presentation called Breaking Through Barriers, Tackling Medical Complexities Locally and Globally. So I always like to start with a proverb. I grew up in Ghana where my elders always say the wise are spoken to in Proverbs. And since everybody here is very wise, I like to say that to a man who only has a hammer in his toolkit, every problem looks like a nail. And I share that to help you think through how some of us in medicine approach problem solving. That we try to make sure we have more than one tool in our toolkit so that we can solve the problems in different ways and come up with different diagnoses. And the framework I use to do everything in life is this framework called content, structure, and style. Content is the medicine you learn, right? Heart failure, the details of medicine that we all know, diabetes, hypertension. Structure is how we think through things. For example, if I come to you and I tell you that my hand is paining me, you can be structured in how you think about it. Your skin, your muscle, your nerves, your vessels, your bones. There isn't much there, but you can be structured and figure out what part of the hand is causing the pain for the patient. There are also some frameworks we use, this one called vitamin D, which I love, which allows us to think of the whole world. And style is just medicine in society. Some of the decisions we make, the cost of medicine, our biases, why we make some decisions, just medicine in society. And so this lecture will be based on this, content, structure, and style. And of all these three things, I'll tell you the one I find most important is structure, structure, structure. And so that's my nickname, and I'm called Dr. Structure. And so that's what we're going to go for today, structure, structure, structure. And so let me help you out. I use structure in everything I do. Even when I decide to go for lunch, I think, do I do internal or external? As you can see, there's nothing except for these two things. Even if I decide to go to the planet Mars for lunch, it's external. And so you can use structure to cover the entire world. When I did the business world, when I was at McKinsey, we used to call it MECE, M-E-C-E, up here. Mutually exclusive and completely exhaustive. And so how can you solve problems in a mutually exclusive and completely exhaustive manner? And I use this in medicine for everything. Someone comes in with chest pain, I think of it as, is it cardiac or non-cardiac? And I like to say, I don't care if your chest pain is caused by your mother-in-law, it's non-cardiac. And this is how you stay structured and you solve problems across the scope. Same as anemia. Someone doesn't have blood. Are they not making blood? Are they destroying blood? Or are they losing blood? You can be structured to figure out problems patients are bringing to you. And so for all those of you on the call, if I came to you, one of your friends came to you and say, yo, I'm really broke. What's going on? And so I ask you, why am I broke? Using a structured way, you can figure it out. You can say, you don't have money because you're not working, you're not making money. You're broke. You're spending too much money. You're chilling, spending too much. Or maybe you're paying too many loans or debt or taxes, right? In a structured way, I can find out why you don't have enough money. And that same framework is the same framework someone will use for anemia, right? You are not making enough money. It's equal to production, right? You're spending too much money. It's equal to loss. And this one, I kind of made it up. Distraction is maybe you're paying too many taxes or you're paying your school loans or whatever it is. But the same framework someone will use for you're not making enough money is the same framework we use for you don't have enough blood in your body. And so the same concepts apply, and I love to be structure, structure, structure. And so that said, let's go into the case. This is a case of a patient I saw in Ghana a few years ago. This is the hospital I work in Ghana. I still do that. I've been working there for the past 9 years. And this is me in the car going into the hospital. The OPD is the outpatient department, and you see folks arriving at the outpatient department to be seen in clinic. And then these are the hallways. I walk through these hallways to get to the male ward. And every morning I come, you see a lot of people sitting outside here waiting. And as I go, some people lying outside here waiting for their loved ones. And the reason these folks are sitting out here is how we practice medicine in Ghana is we go inside, we do our rounds, but then if any medications, any IV fluids, any food, family members have to go buy it for the loved ones. And so if you don't have a loved one, it's really difficult to get care because this woman is waiting for us to run on her husband and go buy the medications or buy the food for the patient. This is how we round. There are 30 beds in the male ward. You see these boxes here is where we store people's medications. They have their paper charts on the table. And we go from bed to bed and we round on all these 30 patients. We do this in the morning from like 8 to 10. And then after 10 o'clock, we go to clinic where we sit at a table. A patient sits here, a patient sits here. And we see patients in outpatient from like 10 to 4 p.m. Not much privacy when you're seeing a patient in clinic. And so if we need privacy to do a physical exam, we go behind this board here where we see patients. I always have to be careful. I'm not wearing the same shirt for this lecture so people don't accuse me I don't buy new shirts. So I intentionally wore a blue shirt today just to be safe. And so this is the work in Ghana. And so this case is a patient who came and sat right here, literally sat right here in front of me. And so I'll share with you the way we present in medicine. This is a 55-year-old man. I don't know his medical history. He comes into clinic and says he's short of breath and he has pains for the past 1 week. Okay. Just short of breath. In medicine, we have a structured way, coming out structure of getting history. We have the past medical history. In his case, he's none, even though he's 55, he doesn't see a doctor often. Medications, he doesn't take any medications. His social history, he lives with his wife, he's a taxi driver, and he doesn't drink, smoke, or do any illicits. And his family history, he's not aware of any medical problems in his family. And so this is the patient that came to sit with me. So he comes in with shortness of breath. And so in the spirit of structure, I was like, let me do a physical exam. And I know some of you might not be familiar with how in medicine we lay this out, but we lay this out from head to toe. This is a structured way we approach things in medicine. I want to know his vitals, check his pulse, his blood pressure, his O2 oxygen saturation. 125 is high. That's why I put it in red. Normal is 60 to 90. So his heart is beating fast. O2 sat is low, 85%. Normal is 92% above, even 90% above, I'll take it. But 85 is low. So that means he's not oxygenating his blood too well. He was in distress sitting there, and he said his whole body, he's in pain throughout. His tongue and his oral part was dry. And when I used my stethoscope to listen to his lungs, he has some wheezes and some crackles, sounds I was hearing in his lungs. That is not normal, I will tell you. Normal lungs are totally clear. You hear the breath sounds nicely. And he had tender to palpation diffusely. When I touch his legs, he's like, my legs are painful. And so what is on my differential for shortness of breath? Because this man is coming in and he's short of breath. And so in the spirit of structure, we are going to approach this with structure. And I have Dr. Guarino here to help me out here. Dr. Guarino, if this man comes to you and he's short of breath, how do you structure this?
Well, sometimes you start by asking more questions to help you figure out, is this a new problem? Is this a problem that's been going on for a while? Because the structure of the reasons or the things you might want to do next can change depending on how long the problem's been going on. And you pointed out some of the other symptoms and the other things that help you think about it. But then you start to go through maybe using one of your mnemonics that you mentioned. Is he short of breath because he has a problem with his lungs, with his heart, with his, not having enough oxygen in his body? And you start to, in your mind, go through this process where you rule in or out or go through and prioritize those possibilities based on what you see in front of you. And then you start to think about what to do next.
I love it, Dr. Guarino. Now, I am no Dr. House, but Dr. Guarino, I think you beat Dr. House here. For those, some of you might be younger, you probably never watched Dr. House and watch more current modern medical shows. But for some of us growing up, Dr. House was what we grew up on, and he was supposed to be very smart. And so I think this is how Dr. House will approach it, but I think Dr. Guarino, you probably did it better than him. Cardiovascular or respiratory, right? If you cannot breathe, it's your chest area. You have two things in your chest. Your heart, the stuff around your heart, or the stuff for your breathing, which is exactly what you said, well, Dr. Guarino. There's not much outside there. Now, someone can put something and say other, your belly or your legs, but that's a little silly. So I think I'll just stick to these two, your heart or your lungs. And when I think about your heart, I think of all these things. Your heart is not working well. You mentioned anemia, maybe it's deconditioned. No, I won't go into the details of this at this level, but we think of things like that controlled breathing, which can make you short of breath, muscles, or even at the level of the alveoli, like how you are, or the lungs, how you are exchanging gas. So as you go through medicine, you go through your training, you learn all these details, and you will learn all these different conditions. My goal is not to go through all of these, but you can, your heart is not pumping well, all of these conditions here. You have fluid around your heart. Your lung is not compliant. You have muscle weakness, so you are not breathing properly. There's so many things that can cause, and Dr. Guarino laid it out for us very nicely. And so the takeaway for you all, I'll have a number of takeaways for you, for those on the line who are listening. I don't care what level you are at, whether you are middle school, high school, college, PhD. My ask of you is structure, structure, structure. Whenever you have a problem, structure, structure, structure. If I come to you and I say, why are you broke? I want my 3 reasons. I'm not making money, I'm spending too much money, or I'm paying too many loans. Whatever it is, structure, structure, structure. That's my one takeaway. And if this is all you remember from this lesson, my job is done. So let's keep going. So this is a summary. 55-year-old man, no past medical history, comes in with shortness of breath and diffuse pains. Does not take any medications, alcohol, or drugs. He works as a taxi driver. And as I said, his O2 sat is low, and we want this to be 92 or so and above. And so what's going on with this man? So we check his blood work. And this is a complicated way to review blood work, but I helped you out and highlighted the ones which are relevant. Dr. Guarino, something is going on here. Tell me more about this, the hemoglobin. What is going on here?
That's enough to give me chest pain, to be honest with you. When I see a hemoglobin of 2.3 as a person who looks at blood counts all the time, the first thing that you often have to stop and ask yourself is that accurate? Or is there something wrong with the test? Because sometimes if something seems so unexpected, you have to just double check yourself. So the first thing I would ask was, are we sure that test is the right test? And then if it is,
right test, Dr. Guarino. So what is normal for us? For everyone on the call, Dr. Guarino, what is normal?
So normal hemoglobin for most people is 12, 13, 14, 15 in that range. So 12 to 15.
Wow.
So
So
this is remarkably low.
Wow. Wow. So this man has lost a lot of blood and he's 2.3 walking around, is what we're saying? Wow.
Yes. Yep.
Okay. So this is very low. Now, for those who are interested, this is the white count. The white count is a bit high. We'll hold off for this. And this is his kidney function, also a low high. We'll ignore it. And for those who don't believe me, when I first saw this number, Dr. Guarino, I was just like you. I was like, this is not real. This man is sitting in clinic with me. Normal is 12 to 15 buckets of blood in your body. And this man has only 2 buckets of blood in his body, or units of blood. That's just impossible. So I took a picture of it. And as Dr. Guarino said, normal can be 12 to 15. We see the normal here. Every blood lab has a bit of a difference in range, but this was 2.3. And so when a patient has such a low blood count, Dr. Guarino, what do I give this patient?
Well, you would want to give them blood right away.
Perfect. Want to give them blood away. And in the US, how many units would you give to this man if he came into your hospital, Dr. Guarino? Just say on average. No perfect answer.
Probably over time, quite a few, while, as you point out, we investigate the reason why this is happening. But I think he would get probably over the course of his treatment, probably 6 units more of blood.
I love it. Well, in Ghana, so for every unit, you go up by 1. In Ghana, this man only got 1 unit, and he went up to 3.5. The reason we could only give him 1 unit is, unlike the US, where you come in and you need transfusion, we give you transfusion. In places like Ghana, when you need transfusion, a family member has to come and donate on your behalf before we can give you blood. It's 1-for-1 exchange. And so because his wife only was willing to donate 1 unit, we could only give him 1 unit versus the 5 or 6 units that we could have given him if he were in the US. And so that's all we could give him, only 1 unit, which was unfortunate, but that's all we could, the system could allow us to give him. And so he went up from 2.3 to 3.5 with that 1 unit. It increases hemoglobin by 1. And so Dr. Guarino, we did some tests. Can you, in 30 seconds, speak more about these tests we did to try to find out why his blood count is so low?
Sure. So I think within the framework of what you discussed, the structure, you have to think about what's unique or what's most likely based on the person that you're seeing in front of you, and what helps you understand why this is happening. And so in Ghana, as in certain places, one of the reasons why people might be this anemic is because of infections. So thus the test for malaria, which is a common infection that can cause anemia.
It was negative.
And all right, so now we have to look for other reasons. And so one of the more common inherited reasons or things that people are born with that can give you low blood counts or anemia is sickle cell disease. Actually, what's interesting about this test is that the test that you did for him, which looks kind of like a urine pregnancy test or something that you do at the bedside to screen for sickle cell disease, isn't available in the United States. And so we don't have this same sort of screen. You have to send a more involved, more expensive lab test to look for the different hemoglobin building blocks.
That's good to know. So we do this in Ghana because a more expensive one is too expensive for us. So we do this quick pregnancy test because it's too expensive. And so his came back as positive. And so what we realized that this man has sickle cell disease. And this is, again, a low high level. So Dr. Guarino, maybe focus on how that, I just want folks to get sickle cell in terms of at the DNA level, at the protein level, at the organ level. And I care more about the organ level. So can you just give us, when someone has sickle cell, what are we saying? What is this?
Yeah. So everybody obviously has genetic code that tells their body how to make all the different proteins that form all the different organ systems of your body. And what is remarkable is that, and you all may be deep in the throes of AP biology or genetics, so you may remember more about this than I do, but the point is everybody's genetic code is made up of different combinations of acids that then make amino acids. And so the code you read from left to right, just like reading words. And so sickle cell is an inherited change of one base pair in the DNA, which then changes the whole sentence. So instead of saying, that the sentence having a code for the normal hemoglobin, you have one substitution that changes the way the whole sentence reads. And then that effect gets magnified because then the instruction is telling your body to make proteins that don't form the way they're supposed to. And so the hemoglobin building blocks don't make a nice pocket for oxygen. And then in your red blood cells, you can't carry oxygen to all of the organs in your body. And so your red blood cells are usually nice and round, shaped like a donut. We love to compare things to food in medicine and ruin them for you for the rest of your life. But red blood cells are typically nice and round like a donut. But the change in sickle cell disease makes them change shape to like a banana, a curved, stiff. And if you imagine donuts trying to flow through tubes in your body, that often works pretty well. If you imagine bananas trying to get through small tubes in your body, it doesn't go well. And so that blockage causes all of the complications that we think about in sickle cell disease.
I love that. So listen, this is all too complex for my small head. For me, I'll go with donuts to banana.
Donut to banana. That's all you have to know.
Banana. That's all I remember. Donut to banana. And in that sense, the banana, again, sickling, and you cause blockages. So I see this here getting blocked versus this is flowing. So all these blockages is what the banana causes blockages. That's what I remember. And so in that sense, just even thinking that, again, I say I'm not the smartest person in the world, but I like to be the most structured person in the world. If all this sickling, all these bananas are forming and it's causing blockages, you can imagine that from head to toe, there are implications. Because we have blood vessels from head to toe. And so in your brain, in your central nervous system, you can get strokes. If these blockages are going into your brain, you get strokes. And so sickle cell patients often get strokes. Dr. Guarino, can you help guide me through from head? This is the lungs, this is the heart, this is the GI system, this is the urinary system, blood infection. What are the implications of this process in the human body if all my vessels are getting blocked left and right?
So all of that blockage over time can cause damage to the tissues themselves. And when your body doesn't have enough oxygen, the tissues start to die or break down. So the acute complications are things that happen when that blockage is there. So things like acute chest syndrome, which is like kind of a really bad pneumonia. Obviously, you could imagine if you have a blockage in your heart, things like heart attacks or myocardial infarctions. Priapism is a prolonged erection that happens when the blood isn't able to drain. We talked about some of the anemia. Those bananas are more fragile than the donuts because the donuts can squeeze through spaces, but the bananas get stuck and they break down. So that's kind of the you're constantly having to make more blood cells to keep up. Infections, your spleen is kind of like a big lymph node in the left side of your abdomen. That gets blocked with the banana blood cells, and it can't protect you from certain bacteria in your environment. Pain is the most common complication from sickle cell. That blockage causes inflammation in your body and very acute pain that can happen anytime, anywhere, in any part of your body. And we'll spend a little bit of time later talking about just how difficult that is. And then, as you can imagine, as each of those tissues have a blockage, even if that blockage resolves, some of the damage has already been done. And so those repeated blockages or episodes build up over time to give you some of the complications that you see on the other side. And so even in the United States, where we have treatments for sickle cell disease, all of these things add up over time and decrease life expectancy by about 20 years, which is quite remarkable.
And so my second takeaway for you all, the first takeaway, those on the line, I said structure, structure, structure. In everything, structure. Similar to this, sickle cell affects people from head to toe in a structured way. I don't need to remember all these crazy conditions in medicine. I don't need to memorize this. I just need to think from head to toe. And so whenever you see sickle cell disease, you have to be sensitive and conscious to the fact that it affects multiple organs from head to toe. And that's my second takeaway for you. If you remember this, the sickle cell disease affects multiple organs from head to toe. I don't care if you remember all these conditions, disarray, all this stuff. Just remember that head to toe is sickle cell disease. And so it's a painful disease to have. And it breaks my heart when I see people with sickle cell because every part of their body is affected. And that's heartbreaking. I circled ACS, which is acute chest syndrome, for a reason. I want to dive in on that because that one, when you were talking, Dr. Guarino, I heard you said it's very scary. So I want to dive into acute chest syndrome. What is it? And I wanted to show the diagram of it. What is it, Dr. Guarino?
So acute chest syndrome is, as you point out, the leading cause of death for people with sickle cell disease, and it can happen quite quickly. So someone who is well or just seems to have a cold when they come into the emergency room can be in the ICU hours later. And so it's something that we have to really think about and take seriously. But what happens is the sickled cells, or the bananas, get stuck in the small blood vessels of your lungs, which is where your blood exchanges oxygen for carbon dioxide so that you can fuel all the tissues in your body. And so what happens is those blockages keep blood from flowing and oxygen from being exchanged, and you get the symptoms of fever, chest pain, your oxygen levels get low because you can't get new oxygen into your body. And sometimes acute chest syndrome isn't an infection in and of itself. I did say it was kind of like a pneumonia, and sometimes the infection causes the bananas to get stuck in your body, but not always. Sometimes it's not breathing well. So people who have surgery or need to get anesthesia, that low oxygen state where they're not breathing on their own can also make those blood cells change shape and cause acute chest syndrome. So it's something that when you're thinking about the structure, you can also look deeper to see what's causing the acute chest syndrome too.
Now, there are different types of learners here at different levels, but we're going to go in deep and we're going to think PhD level with diagrams. So Dr. Guarino, you kind of described this properly, and maybe jump in case I am being too simple about it. You have this vaso-occlusive crisis, as you said, donut to banana causes obviously all this crisis leading to occlusions. Part 2 is this stuff goes into the lungs. Infection can form on top of it. You talked about how this can cause, lung-causing pulmonary infarction or pulmonary blockages. That leads to what happens. When that happens, the body reacts in such a way that there's shunting. And by shunting, meaning blood and air are not in the same place. Because if there is no blood in a certain, air comes, and where the blood is not, there's blockage. It's a waste of air. And so there's what we call shunting. Am I describing it right, Dr. Guarino?
Yeah, your body is pretty smart. It tries to adapt the systems to get the most work done, and that means not sending blood to places where the gas isn't being exchanged.
Exactly. And because of that, what happens? You get more desaturated hemoglobin because that hemoglobin is not getting oxygen, which leads to decreased oxygen delivery, which leads us back to where we started from. And so I share this with you. This is a positive cycle. There are not many positive cycles in the world. The whole world is positive, negative, yin and yang, right and left. This is one of the few processes in the body that's a positive feedback loop. And that's what makes this crazy scary. And so when a patient has acute chest syndrome and you are locked in this positive cycle, that is ridiculously scary. And so the second takeaway for you as part of takeaway is fear acute chest syndrome. I don't remember all of this thing in detail. I don't expect you to remember all this diagram in detail, but I want you to remember that fear acute chest syndrome. Be afraid of it. Sickle cell disease affects everyone from head to toe, but please be very afraid when you see acute chest syndrome. Am I encapsulating this, or Dr. Guarino, or am I exaggerating?
No, I think that's really an important point to make. And I think it highlights the need in medicine to work in teams, because even if all you know is acute chest syndrome is bad, then you know enough to reach out for help, and that gets patients what they need. So I think one of the most important things sometimes is to recognize in medicine, we learn to know sick or not sick. Do I need to worry or not worry? And that's maybe one of the most important things, because once you decide that, you ask for help and go through different pathways.
Yeah, Dr. Guarino is a hematologist. I am an internal medicine doctor. And I tell you, when I see acute chest syndrome, I immediately call Dr. Guarino's team, because I know this is something I need help with, and I cannot be proud and think I can do it by myself, because somebody's mother, somebody's father, somebody's son's life is at stake. And so I call Dr. Guarino's team immediately for help. So fear acute chest syndrome. So this is content, structure, style that we talked about for quite a while now. Now I want to talk about style and the style of medicine where I mentioned. And for style, I would like to start with this quote, because with sickle cell, different parts of the world, even the US as well, we see a lot of disparities. And I love this quote from Paul Farmer, who wrote a book actually I read before I started college at Dartmouth. Our entering class all had to read this book, Mountains Beyond Mountains. And it's what catapulted a lot of people into global health. And Paul Farmer actually said a while ago, he was one of my professors when I was a student, that the idea that some lives matter less is the root of all that is wrong with the world. And so I want to talk about pain specifically. And Laurie, I would like to get your perception about pain in sickle cell patients. Can you speak more to this?
Yeah, absolutely. I'm happy to kind of kick off the conversation about pain. I know we've touched on it before, and you guys will definitely dive into the more technical pieces of pain. But one of the big things to really discuss today is that there's so many misconceptions surrounding pain and as it occurs in our sickle cell patients. So to kind of break it down, I'm going to kind of paint a little picture. So you're a doctor, you're working in the emergency room, you have two patients that come in and are stating they are in pain, they need care. So you have patient A, in one side, he's moaning, clutching his knee, sweating, crying, and keeps repeating how much his knee hurts. You have patient B, who seems a little withdrawn, shifts back and forth occasionally, is on his phone playing a game, quietly talking to his girlfriend. So being the doctor in that situation, which patient do you immediately think is in pain? I can imagine most people would probably say patient A, but actually the answer is both. And I think it's really important to use this example to highlight what we believe the perception of pain should look like compared to the reality of how pain presents in our patients who are here for treatment. So working with the healthcare field, we're constantly faced with the ongoing challenge of checking our bias and reflecting on care that we provide to our patients, just to ensure that they're being treated fairly and equitably. So it's always really important to remember that sickle cell patients, they're living their lives in both chronic pain and acute pain. So their crises are unpredictable and they're impacted by so many different factors. Kind of highlighted a few here: medication regimen, stress, emotions, lifestyle habit, and coping skills. And one of the really important things to highlight are those coping skills that they've spent years developing. So you have patient A, they might best manage their pain by emphasizing how he's feeling to his doctors, by verbalizing it, moving around, and having that physical touch where that pain is stemming from. Whereas patient B might feel a little bit of relief by distracting himself and talking on the phone or playing a game and limiting his movement as much as possible. So I really like to focus on those coping skills because we kind of are going to talk, later on about improving pain management and access to care. And one of the things that our team works on and is constantly revising are individualized pain plans. And I think it's important to, not only outline the medication that's needed in order to treat these patients, but also really specific ways to understand their habits and their behaviors and know how it presents in them. And it's just, really good to continue to educate our teams on kind of those different perceptions of what we expect pain to look like versus what the reality is of it.
Thank you, Laurie. Thank you so much.
Yeah.
And so I know, Laurie, if you can speak to that, because obviously there's lots of data about physicians not believing self-reports. Can you speak more to that and how that impacts patients?
Yeah. Oh, absolutely. So I know it's kind of broken down here. What the negative stigma is that's associated with our sickle cell patients, and also how physician bias or caregiver bias can lead to poor pain control and care management. So kind of highlighted here are 3 key areas that are attributed to negative healthcare provider attitudes. Those being physicians not necessarily believing what the patient is reporting about their pain, physicians assuming a patient is drug seeking because they specifically know what medication and the doses that are needed in order to best manage their pain. And then lastly, kind of believing that the dose that they're asking for maybe is a little too high or they're getting it a little bit more frequently. So kind of in these situations, I do encourage you to put yourself in the shoes of those patients. You're a person living with sickle cell disease and you rely on a healthcare system frequently for support. So I would ask you kind of how would you feel if you, went to go seek care in an emergency room or a hospital system, and the physician that was providing care to you had responded to you with any of these kind of combinations of questioning, right? It can kind of lead you to feel maybe unsupported, maybe make you feel a little discouraged, frustrated, maybe even embarrassed. So these types of encounters are kind of what continue to drive that divide in the relationship between our healthcare providers and our patients.
Thank you, Laurie. And Laurie, actually, I'll share with you the data. These are a bit old, but the data that 86% of MDs don't believe that self-report is the best indicator for pain. 50% ED physicians and hematologists believe patients are addicted, and 63% of folks also believe that addiction develops. But when you look at the data for sickle cell patients, it's actually lower than other people when it comes to the use of drugs in an inappropriate way. And when you look at opioid-induced death, dying from opioid use, sickle cell patients are actually lower than people with back pain or migraines or other conditions. And so these stereotypes, I love how you said it. It doesn't, there's no reality to them, but it's bias and perception. How do we address those? And I love this, and I'll talk about this. This is a study that was done at Hopkins, which talked about do words matter? Stigmatizing language and the transmission of bias in medical records. And we all, write long notes about patients. Medical records have become a thing now. And this study was done at Hopkins looking at biased language versus neutral language. So imagine a patient coming in and they say, oh, he's a frequent flyer, versus, no, this patient has 8 to 10 acute pain crises per year. Or, oh, he appears to be in distress, versus he's in obvious distress. Or, oh, he's refusing to wear his oxygen mask and is insisting that his pain is 10 out of 10, versus he's not tolerating the mask and his pain is still 10 out of 10. And when the study was done, it actually showed that those with neutral language actually got better pain management than those with stigmatizing language. And so even the language we use matters. It influences how people perceive pain and how people treat pain in sickle cell patients. This is a study, the report that came out years ago. I started teaching about this, and then it was on the Daily Show as well. And so people, they took credit for it, but medical students and residents often believe that Black patients have less pain. It was a small study from the University of Virginia, and the ends were small, the numbers were small. But if you look into the data, 25% of residents believe that Black skin is thicker than whites. And that's a problem. And so some of these perceptions influence the biases and how patients are treated for pain.
And
Laurie,
can
can
I
you speak about barriers?
can I-
Yes.
Can
Dr.
I add
Guarino,
one
jump in.
thing about that
Yes.
Hopkins study? The Hopkins group, when they were looking at treating pain and the language that you use to talk about patients, they looked at ways to address that bias in clinicians in the emergency room. And the one thing that they found that can improve that is by sickle cell clinicians putting a humanizing statement in the chart. This patient is a 26-year-old who likes to design sneakers and has 3 siblings at home. And so I think it's a stark reminder that one of the best ways to address this is to think about your patients as people outside of the disease or the symptoms or what you're seeing in front of you.
You are so right, Dr. Guarino. Over the years, I've seen so many patients with diabetes, hypertension, sickle cell, and all these cases. And I don't remember the clinical stuff, but I remember my patients who was a bread maker, and during COVID was talking about how he wrapped up his bread making so that people can get bread whilst they're in their house. Right? These are the stories about patients I remember. And then based on that story, I remember, oh yeah, that man had diabetes. But the diabetes doesn't come first. I first think of the humanity of that patient and then later on link it to their condition. So thank you for saying that, because that's what makes us better clinicians, to realize that everybody is somebody's mother or somebody's father or somebody's brother, somebody's sister. Thank you so much for that. Laurie, I'm going to come back to you. What are some of the barriers to improved health outcomes?
Yeah, no, absolutely. And there are several, and they are not even, all of them are not even on this slide. So I think one of the big things that we've already kind of touched on is the mistrust of healthcare institutions. We can kind of understand why it's hard to get patient buy-in when they've experienced years of discrimination and ignorance to their care. So they're often kind of left thinking, well, why now? What's going to make this different? And so kind of highlighting, circling back to what Dr. Guarino mentioned is, recognizing that these are, people and they have a life and they have a story. So how can we tie that in to build a relationship, get to understand them, and provide the best care as possible? Transportation is another really big problem with getting people back and forth to appointments. People living with sickle cell have so many appointments, and it's not just hematology appointments, it's infusion center appointments, it's imaging, routine screenings, primary care, labs, the whole gamut. And oftentimes you have people living in healthcare deserts, so they are not directly accessible to a care center. Oftentimes traveling several hours from home, even in a very small state like Delaware. We have patients traveling from downstate that it takes them 2+ hours, 3 probably in the summertime with traffic, to get, one way to the hospital and back. So you can imagine that takes up an entire day traveling for one appointment, which can be exhausting, and it can lead to a significant issue with work and home life as well. Another area is medication and treatment. They require extensive authorizations through insurance companies, and that typically relates in a delay, causes a delay in care. So one of the main lines of defense for helping a person with a sickle cell crisis is an infusion center appointment, typically same day, next day appointment, but sometimes insurance barriers can lead to a delay in that care. So it requires staff buy-in and having a knowledge basis to advocate to these insurance agencies on the behalf of patients. So that's always really important to think about the backside, the team part of it, right? That goes into providing this care. Nutritious food, kind of talking about what contributes to pain. It's lifestyle, and part of that is giving really good, healthy, nutritious food to your body to help, keep you as healthy as possible. But often that is really unable to be accessed because of cost. It can be very expensive to eat healthy, nutritious, organic, food to give you that nutrition that you're looking for. And then lastly, is lack of funding. It is very well known that sickle cell disease is an underfunded, undersupported, and that unfortunately it limits a lot of access to further research on the disease as well as development of medication and treatment services.
Thank you, Laurie. Sickle cell is underfunded. So ways to improve? Yeah,
no, that's kind of what we're trying to do here today, right? We're trying to talk about these ways to kind of combat these issues. So we continue to try and break down that through continued education of our healthcare providers. So having patient-specific teaching moments. I'm sure Dr. Guarino can probably speak to this way better than I can about, getting a call about, consulting on a patient and using that as a teachable moment. Meetings, conferences, even events really like today, being able to kind of start that conversation early and kind of prevent that bias from continuing in healthcare. And then continued advocacy on the local, state, federal, areas to be able to improve the development of medication and gain funds to be able to do further research. And then lastly, the one and kind of I would say the biggest and most important way that we can improve is providing access to our patients to community-based organizations. So I tried to highlight the two that we have here, Sickle Cell Association Delaware, as well as the Healing Tree. And they work directly alongside our patients, boots on the ground. They organize blood drives to make sure that we have blood to be able to, give these to our patients to kind of help them. They help to cover those transportation costs to get them back and forth to their appointments. Help to connect them with fill their fridges with food that can help to be just not only for them, but their families. They help with covering the cost of medications, especially over-the-counter ones that aren't typically covered by insurance, but are necessary. And I think that probably their most beneficial reason that they are here for our patients is that they do develop a community for our patients. So they connect them with other individuals living with sickle cell, and they develop a sense of support, and they have the ability to now turn to someone next to them and say, I have sickle cell disease. And the person next to them says, I know exactly how you're feeling. And that can really go wonders for a person's mental health to help kind of get them through living with a chronic illness.
Thank you, Laurie.
Yeah.
And so, talking about treatments, everything Doctor about investments, etc. Treatment is important. There's protocols for treatment. I won't bore you with that. But in October 2023, just recently, the FDA developed a new drug for sickle cell. Dr. Guarino, any 2 seconds on this drug? Anything that you want to mention, talk about this drug? Please don't tell us the cost, but anything else you want to talk about this drug? Oh, you're mute, Dr. Guarino.
If we go back to what causes sickle cell disease, don't go all the way back there. That's way at the beginning.
Yep.
But the point is, it's a one base pair substitution that causes all these problems. And so wouldn't it be nice if we could just change that base pair back to what it should be to give people hemoglobin A? And then that, I think, is what many of us are looking for as a cure or to get rid of some of the complications. Because a lot of what we've talked about already is responding to complications once they've already happened. And that's never a good thing. What if we could prevent these complications from happening? And then you go back to the root cause, and that's that genetic change. So can you give the cells basically a new instruction manual to make hemoglobin with the right sentence so that you get the right hemoglobin? And that's the thought behind gene therapy.
I see. We get the donut and not the banana. I love it.
Exactly.
So what do people think the cost of this treatment is? And for those of you watching this on your phone, I'm sorry, you probably won't be able to scan this. But if you're watching this on your laptop, I want you to scan this because I want to hear from you all what you guys think is the cost of this medication. And I'll leave this on for a little bit and let people scan. Now, if you have two phones, then that's a little sketchy. You got to tell me why you have two phones and you can scan one phone with the other phone. That's a little sketchy. But if you have a phone and a laptop, maybe, or an iPad, you can scan this on your phone. And I'd like to hear your answers and see what people think the cost of this medication is. I'll give you 10 seconds to scan this. Then I'll keep going. For those who have only one phone, I'm sorry. It's hard to scan this when you have one phone. All right, so this is the question. What is the cost to treat one patient with a new drug for sickle cell? So let me see, answers are coming in. Let me project your answers so you all see what people are thinking. Ooh, we have a lot of various answers up here. Most people think it's $80,000. I love it. 80,000 for the win. Maybe 5 more answers, and then we go from there. Ooh, $80,000 for the win. Most people think this genetic treatment costs $80,000. 70% of our audience thinks it costs $80,000. Well, folks, I'll give you the answer. This is how much the drug costs. $2.2 million. FDA approved this first genetic. This is news from 2024-2020. This is recent, just a year ago. And it's 2.2 million per treatment. That's crazy. I know someone saying, oh, sickle cell affects a lot of folks who are, who are in the Medicaid kind of cost bracket. And so this is very expensive. And this does not even include the hospitalization, the harvest, and all the stuff. And so how are patients supposed to pay for this, right? I see the number of O's, right? The 80,000 people, I wish it was 80,000. $2.2 million. Any comments, Dr. Guarino, on this?
As you point out, that's just the cost for making the cells with the new instruction manual. There's a lot of other costs to the treatment to prepare somebody, to support somebody after getting gene therapy. But on the flip side, you also have to think about the whole person. The results are quite remarkable, at least so far. People go from having 24 hospitalizations in the year prior to getting gene therapy for acute pain to 0 afterwards. And so if you think about the cost of each hospitalization, the cost of that meaning someone can't go to work or can't go to school or can't participate in caring for their family, and then they don't have that burden anymore. If you look at the cost over time, the idea is that overall, in terms of both healthcare and kind of quality of life and productivity, you end up coming out ahead. But that also doesn't address the supply, and because we're still limited in how many people you can prepare these cells for. So it isn't a cure for everyone right away.
Thank you, Dr. Guarino. 2.2 is expensive. That's all I got to say. So in that case, let's keep moving. Let's keep moving. So let's wrap up soon. 55-year-old man comes short of breath, sickle cell disease. I'm going to wrap up in the next 5 minutes. Develops acute chest syndrome. And as I told you, fear acute chest syndrome. We put him on oxygen in Ghana. This is the oxygen tank. And I took a picture of the patient's arm. They're so big, we don't have portable x-ray. So if a patient is getting short of breath and need an x-ray, I tell you, I'm not the strongest doctor. I can't carry this all the way to x-ray. And so often we get into trouble with how we practice medicine in Ghana. The next day I came to see the patient, and this was on his chart, that this patient is to pay 50 Ghana cedis for oxygen. 50 Ghana cedis at that time was like $10. So because of $10, this man was not given oxygen. And I told you that acute chest syndrome is a positive loop cycle, and it's very scary. And so without oxygen, he was getting more bananas than donuts. And little by little, he got sicker. We sent to the ICU and he passed away, unfortunately. And this was heartbreaking for me to see that because of $10 of oxygen, this man passed away. And so the takeaways I have for you is structure, structure, structure. I take that very seriously. Sickle cell disease affects you from head to toe. Fear acute chest syndrome. Be afraid of it. Call for help. And then be careful about the words you use when you describe patient, because words matter. We talk about pain and some of the biases, and we also talk about the cost of this medication. In 2 minutes, maybe I'll use this as an opportunity to tell you a bit about my story of global health, and then I would like to take questions. I started with a proverb, and I'll end with a proverb that the river that forgets its source runs dry. Coming from Ghana, for me, it's very important to remember where I came from and how I can help people. And so I talked about, once I finished doing work in the business world, I was a firm chief at Harvard Medical School. I was doing global health through this WHO collaborating center also out of Harvard. And I sat on the Africa, which I still do, on the Africa CDC Advisory Committee with 13 other experts. And the work we were doing is, WHO often thinks of diseases as exercise, stop smoking, eat healthy. But when it comes to some conditions in Africa, the ones on the right-hand side here, there are these things which are severe non-communicable diseases. Sickle cell is one of those of it, right? It's a genetic thing. I can't eat healthy or exercise and I won't get sickle cell. And there's not much investment in them. So we worked very hard. We wrote this paper in the Lancet to bring awareness to this and to bring more funding to this. Rheumatic heart disease, type 1 diabetes, sickle cell. And we got a lot of traction. We had this symposium at Harvard years ago, bringing a lot of experts to the table. And these are the countries I worked in. All these countries, mainly the ones in West Africa, Ghana, where I'm from, Burkina Faso, Benin. And Africa health ministers voted to make this a strategy for the continent in 2022, which was huge for us. Because now we have the ticket to go to every Minister of Health in every country to actually implement this strategy to help sickle cell patients, help type 1 diabetes patients. And so I was traveling, this is work the team was doing, traveling. During COVID, we had this virtually. This was actually the Minister of Health of Nigeria who came to this meeting with experts and leaders from every country, Cameroon, Nigeria, Benin. And then when COVID restrictions, I could travel, I started traveling. This is my trip to Democratic Republic of Congo. This is Senegal with experts from Africa, WHO, Afro from all over Africa. And this is my trip to Ghana with the Ghana Ministry of Health. And all of these, my beard seems to get bigger and bigger and bigger as I go along, telling you I was working very hard. And then this is the Africa CDC group that I still sit on, the 13 advisors who sits with the Africa Union, working with member states. This was our meeting in Kenya last year, 2 years. Last year we met in Tanzania, and this year we are yet to meet as a team. We actually have our first meeting on Friday virtually before we all travel and pick a country to meet us. And I share this with all this work is what brought me to Wilmington, to Delaware. That's Chief Medical Officer. I like to say, at the risk of sounding arrogant, I'm not here to be a CMO for the hospital, but for the community and for the city and for all these patients, like these sickle cell patients we mentioned. And so this is how I now split my time. And the role of a CMO, most of you say, what does a Chief Medical Officer do? Clinical leadership, strategic leadership, but I really focus on the public relations and advocacy and how we can support our patients. And so I'm often out in the community talking to different folks, different churches, different community members of how we can better support the community. And so I'll end with this quote from Nelson Mandela. I was in South Africa years ago, and I went to Nelson Mandela's old house, and I love this picture, this quote that Winnie Mandela wrote him as a letter when he was in prison. And Nelson Mandela replied with this, that in judging our progress as individuals, we tend to concentrate on external factors, such as one's social position, influence and popularity, wealth and standard of education. But internal factors may even be more crucial in assessing one's development as a human being. Humility, purity, generosity, absence of vanity, and readiness to serve our fellow men and women. Qualities within the reach of every human soul. And so thank you all. This was a great fun to be, if we can see your great fun, and we'll stop here and ask questions. Thank you to Dr. Guarino and Laurie. Very much appreciate you. I'll stop here.
All right, thank you very much.
I will just say one thing. When Dr. Mensah first came, sometimes chief medical officers, you can't even find their office. You don't even know where they are or what they do. You just get emails from them about new policies. And so I like to invite all of our leadership to come visit our clinic and to come see patients. And you're still the only one who's taken me up on that. So this is a very authentic, he really does practice what he preaches. So you got to hear from a very, very good person tonight.
Thank you.
All righty. Well, thank you very much. That was a dynamic, enjoyable interchange between the three of you. Probably one of the best that operated that way that we've had. Nicole, I'll turn it over to you to ask the first couple of questions.
Yes. So this question came in, I think, when we were addressing the 55-year-old patient's social history and that he works as a taxi driver. So Laurie asks, I think that has to do with probably the lung sounds that you were talking about. Says, can it be from constant exposure to carbon dioxide from the fumes from driving the taxi?
Laurie, and Dr. Guarino can help me. Laurie is thinking, I love it, Laurie. Again, structure. And so when you think of all the things in the world, could that be possible? And yes, it's on the differential. Absolutely, I'll have it on my differential. And as we do X-ray imaging, blood work, it's definitely on the differential. You know, people get methemoglobinemia, carbon monoxide poisoning. So it's definitely possible. Dr. Guarino, I don't know if you have any comments on that.
No, I certainly think we always keep asking why. Why is he anemic? Why is that? And so that certainly is one of the possible answers to why.
Exactly. So great, Laurie, on the track to becoming a clinician already. Good kudos.
The next question says, can blood transfusions, same person, Laurie, can blood transfusions help with some of the symptoms of sickle cell?
Laurie's killing it.
Lori, it sounds like you want to be a hematologist. Love it. So yes, that goes back to the treating the underlying cause and preventing complications from happening. If you give your body more blood cells, more money coming in, right, then you can do more with it to prevent some of the complications from happening. That has its own risks, but yes, it is one of the things we do quite often.
It's kind of a two-parter. So is sickle cell hereditary? And in this particular patient, why didn't it not appear until later in his life?
Wow. I had slides for this answer and I lost my slides. Dr. Guarino, over to you. This person beat me.
Yeah. So it is hereditary. It means you're born with it. You have it from birth. It's not something that you develop later in life or catch. Some people, as we've seen in this case, don't know that they have it until later. And why not? Because they don't have maybe the same access to healthcare, or they haven't had problems. But in the United States, we screen all babies for sickle cell disease and other inherited medical problems. In every baby that's born in a hospital or even at home gets a newborn screen. So early in the baby's life, while they're still in the hospital, you prick the heel and you put 5 blood drops on a piece of paper and it gets sent off to the state. And the state, every state screens for different panels of inherited medical conditions that we could treat or address early on. And sickle cell is one of those. So newer projects are looking to expand that same screening to be more universal. So he always had sickle cell disease. We just, because of a variety of reasons, didn't diagnose it until later.
So there's those resources. And for him, the other thing is the different types at the genetic level. There's SS, there's SC, and other types. He was SC. And so they often don't get symptoms that much, but when they get it as the same strength as SS. So this man was most likely SC. And that's why we kind of got fooled in the beginning.
Okay. And then I guess this also has to deal with, I guess, like healthcare in Ghana. So this person says in Ghana, if a family member has to go get the medication for an inpatient, where do they go to buy it? And then what happens if the medicine doesn't work and they have to get a different medicine?
So we are very thoughtful about that. So there are pharmacies across the hospital, across the street. So the family has to cross the street and go buy from the pharmacies. So let's say you need an IV antibiotic. We as physicians are very thoughtful. I know you need 7 days of antibiotics. I actually only ask the family to go buy 2 days. Because if we need to change antibiotics, I don't want them to spend all their money to buy 7 days and then we change it from ceftriaxone to meropenem or something. And now they've wasted their money. Also, resources are very limited. These medications are very expensive for patients. So it's a very practical question. We think about it every time. Let's make the right decision, but also let's limit it, see how it works before we ask them to spend more money. So very good question.
And then I guess on the topic of medication, we were talking about the $2.2 million new one. So Zach asks, how well would this new medication take effect for sickle cell patients?
Guarino, this is all yours. If the question is too hard, it's Dr. Guarino. If enough, it's mine. Guarino, over to you.
I only have to focus on the blood, then you have to worry about everything else. So for some things, it's quite good. For treating or preventing complications, new complications from sickle cell disease, it's quite good. Patients almost have virtually no pain after treatment with gene therapy. However, it can't reverse the damage that's already happened. So for people who have had strokes or changes to their brains or scarring in their lungs or changes to their bones, often gene therapy can't reverse that from happening. So it's also challenging to think about when to do gene therapy in someone and how to balance the risks with the benefits.
And this is still going along medicine, but this is more prior auths, the fun stuff. Has anyone thought of creating a team that just handles those for primary and specialty practices to better address the delays in patient care?
I bounce that to Laurie. Laurie, can you help us?
Oh, it's a great thought. And yes, so depending on the size of certain, sickle cell teams across the country, they do have embedded, prior authorization specific staff. Our team specifically, I can only speak to, we have a few team members that do handle this, and oftentimes we'll complete the authorization same day as the request. Where we see a lot of the delay that comes back is the review from the insurance team.
Insurance.
Yeah, insurance is like a blessing and a curse. So, oftentimes our team will submit that authorization immediately upon receiving the information that it needs to be submitted. But insurances typically have a 72-hour window for turning around their determination for the authorization. If it's approved, great. If it's not, then it leads to an appeal that typically the doctor needs to complete, which can take longer. And depending on the insurance, it can actually take up to 2 weeks for an authorization to be approved. So that would actually be a really great area to try and improve that turnaround time from the insurance companies. But I also agree having an embedded, team for prior authorizations is always a benefit.
So the average physician and their staff spends 14 hours a week dealing with prior authorization. And so I don't know about you, but probably you're not thinking about a career in healthcare to shout representative at an automated menu for 14 hours out of the week. So it's one of the things that kind of is one of the biggest pain points, I think, in the practice of medicine, and something that we keep trying to address.
Yeah, and I can only imagine as a physician or even like social worker, you're probably screaming way more often than the individual person is. You're doing it for multiple people. So it can probably be exhausting on that too.
And oftentimes you feel like you're speaking just to like a robot on the other side of the phone. You're like, where's your heart? Let me talk to you about this person.
Right.
Let's share this story. Come on.
Now for this one, I guess it can reword this, but if you were to carry the sickle cell trait, does that necessarily mean that you will develop the disease or have the disease upon being born?
That's a good question. And so typically we counsel patients that people with sickle cell trait don't have the same list of complications or symptoms that we've discussed already. We are learning more that there are some things with sickle cell trait that are unique to those patients. And so there's a big study going on right now to look at the health of people with sickle cell trait to learn more, but you don't have the same complications that we've already talked about. It is important to know that you can pass down that trait to the children that you have in the future, particularly if your partner has another hemoglobin challenge or hemoglobin trait. So I don't know what's on the dating app these days, but maybe hemoglobin status is one of the questions that you want to screen some matches with.
That would be an interesting feature to add.
I mean, Dr. Guarino is joking about the dating apps, but in Ghana, it's a big deal. I have had friends and colleagues, and if there's a concern for sickle cell, it actually has prevented people from getting married culturally. People have actually stayed away, so it's a big deal. It's real.
Oh, Tim, did you want to take over?
Sure, I'll ask a couple of questions. So Allison asks, to do work like Dr. Mensah has done across the world, specifically looking at patients, would you recommend specializing in global health, or would primary care and participation in an organization like Doctors Without Borders have a similar impact?
So life is about opportunities and being prepared for them. And I think I wanted to do a PhD in mathematics, to be honest with you. I studied biology and mathematics at Dartmouth. And so it's all about passion and where you want to go. And I'll share with you a quote. When I was in med school in our dorm, we used to live in this dorm called Vanderbilt Hall at Harvard. And at the roof, every day I used to read that quote by Louis Pasteur. It says, "Dans les champs de l'observation, l'hasard ne favorise que l'esprit préparé." Chance favors the prepared mind. And so I think if you're prepared and the right opportunities come your way, whether it's whatever it is, whether it's in research, education, clinical, whatever it is in global health or whatever topic, and you have that passion, you'll get there with the right mentors and support. And that'll be my answer to that.
Laurie's on fire here. Is sickle cell more prominent in males or females?
Good question. It's equally split. There's no sex predisposition.
All righty. And also, is it like color blindness where you can be a carrier but not actually be symptomatic?
I don't do eyes. The ophthalmology is not my thing, so I don't want to speak about color blindness. But yes, you can have sickle cell trait and not have many symptoms from it.
And let me add to that, Dr. Corey. So I was told years ago in Ghana, the joke we do is there are two people in a room. Mosquitoes will bite one person, will never get malaria. The other person gets malaria. And the one who doesn't get malaria is accused of being a witch who turned into a mosquito and bit their friend. And I think that it's a true joke, but once you have a carrier for sickle cell, you're less likely to get malaria because of the traits you have. And so it's a development we develop, especially for people in Africa, that minimizes the chance of getting malaria. And Dr. Guarino, correct me if I'm wrong, or it's a myth I'm playing with.
No, if you look at a map, the where sickle cell is most common is the same distribution as malaria. So that is part of the reason maybe why it's persisted.
Alrighty. How can we increase awareness to the community about sickle cell disease?
It says Laurie written all over it. Laurie, over to you.
Shouting it from the rooftops. I think, you know, truly, there's always great ways to spread the awareness. And I think kind of circling back to those community-based organizations and supporting them in whatever social outreach that they do, community-based events, as well as events that are held through the healthcare systems as well, do a really great job of bringing this, you know, disease to kind of to light. So I know New Moores Children's Hospital does some really great awareness. They do sickle cell science fair, you know, coming up in June at Christiana. We're celebrating World Sickle Cell Day, where we kind of stand in the lobby and just talk to people who pass by to, you know, let them know that what we're doing there and what we do here. So always just kind of talking more about it and sharing more, and also kind of talking about it in more of the reality terms versus kind of spreading those misconceptions to gain a little bit more support for you know, this population.
Right. And then what can we do to improve the life quality, I assume this means, for the patient?
So I think in all chronic diseases, right, when you think about what makes someone healthy, the answer is medical care actually matters very little. And so certainly optimizing kind of the treatments that we're able to provide to them. But the bigger issues are, you know, the environments that people live in, their educational opportunities, like Laurie discussed, the food that they eat, the environment that they live in, the pollution, things like that. And so sometimes people talk about health in all policies. So if you think about the way that each decision can impact someone's health outside of just the medical care, that's really the bigger way that we improve quality of life. And it's expensive to take care of people who are sick or who have complications. And so the easier thing is to keep those things from happening, right? And that actually ends up saving people and society money, but it requires sometimes a shift in our thinking and our priorities that are hard to overcome.
And I'll add one comment to that. You know, Francis Peabody, who was a famous neurosurgeon in Boston, said, the secret of the care of the patient is in caring for the patient. And so when you truly care about the patient in front of you, not just a number, you improve their lives. It's really about the care we give to people. Forget the medicine, forget the technicalities. It's truly about caring for this person in front of you.
One of the other things that I've also found in thinking about this question is that paying attention to the caregivers of the patient at home and whatnot can be a very useful adjunct, additional thing to do to make sure that the patient and their supporters are all, you know, being paid attention to. Nothing says a good break like some good respite care. This is a more general question, but I think it's relevant for any mini-med. How do you determine if a patient is a drug seeker or if they are truly in need of medicine without seeming condescending or doubtful?
Maybe we can all speak to this. Maybe I'll start with Laurie first before we all jump in, because Laurie, this is definitely in your wheelhouse, and your support is always helpful when we have these challenges in managing patients.
Yeah, I mean, it's really important. I mean, one of the best things to kind of start with any conversation with a patient is meeting them where they are, right? Not where we think that they should be. So, the best way to kind of get to know a patient and try and understand kind of what they're coming in for and what the treatment is that they're seeking is to ask questions, learn from them, get a better understanding of their medical history and their social history as well. Kind of also, touching on everything that goes into their care and what makes them feel well and supported. So going in with an open heart and an open mind and just having a conversation about who this person is in front of you and learning from them can really open up some really good conversation to then make a better decision for treatment on the provider side.
I love that. And my side is internally checking my own biases. I always think about what biases am I bringing to the table when that patient is in front of me. Anything for you, Dr. Guarino?
Yeah, I think just taking a step back and thinking about being curious, not judgmental. Like Laurie said, asking questions, trying to understand more. And, you don't always get it right. And so being honest about that with yourself and with sometimes patients or other team members, I think is really important. And I like to say that medicine is a team sport. So if I'm worried about something or want to double check, I'll call somebody else. I'll call another team member. I'll ask another clinician to help because, I think we all want to do what's right. And even when patients face challenges in the ED, I try to remind anybody, right, that nobody wants to take bad care of patients. We just may not have the right information or the right education or have some blinders on. And so reevaluating that, I think, helps us move forward.
Ready. Well, again, thank you, the three of you, very much for an outstanding presentation. And to my colleagues, Nicole and Christy, thank you for helping out this evening. Next week, a case of the woman with rheumatoid arthritis not responding to typical treatments. Have a good evening, everybody. Good night.